If you have ever sat in a doctor's office and described your symptoms, the fatigue, the weight gain, the brain fog, the sleep that stopped working, and been told that everything looks normal, I need you to hear something. You were not wrong about what you felt. Your doctor may have been. And today, I am going to tell you exactly why. I am a board-certified internal medicine physician with a fellowship in women's health, and I have spent 22 years in clinical practice working almost exclusively with women navigating the menopausal transition and everything that comes after it. I have guided over 200 women through menopause, and the number one thing those women tell me, the thing that genuinely breaks my heart, every single time I hear it, is that nobody explained any of this to them before it happened. Not what was coming, not why it was happening, and not what their options were. And all of that ends today. In this video, I'm going to walk you through 5 things about menopause that most women are never told, not by their primary care doctors, not by their OB/GYNs, and certainly not by the mainstream health conversation. I am going to start with something that surprises almost every woman I share it with. Menopause is not primarily a hormone loss event. It is something far more complicated than that. And understanding it will change the way you make sense of everything your body has been doing for the last several years. Stay with me through all 5 points. By the time we get to number 4, I believe most of you are going to understand something about your own health history that you have never been told before. Number 1, the perimenopause window. Nobody warned you about. Let me start by asking you something. When did your symptoms begin? Not when you had your last period. When did you first start noticing that something felt different? Your sleep changed. Your weight shifted. Your mood became less predictable. Your energy was not what it used to be. For most of the women I treat, that answer is somewhere between their early 40s and their late 40s, not 51, not 52, years earlier. Here is what that means clinically. Perimenopause, the hormonal transition that leads to menopause, can begin anywhere from 7 to 10 years before your final menstrual period. For many women, that means their mid to late 40s. For some, it begins even earlier. During perimenopause, your estrogen does not simply decline steadily and predictably. It surges, it drops, it surges again. This erratic fluctuation, not the eventual decline, is what drives the majority of the symptoms women experience. Hot flashes, night sweats, mood instability, disrupted sleep, brain fog, joint pain. These are largely the result of estrogen behaving unpredictably, not just disappearing. What the research shows is that the average woman spends 4 years in perimenopause before her final period. But the range is enormous. Some women transition in 2 years. Others spend a full decade in this hormonal fluctuation before reaching menopause. Here's what you can do with this information today. If you are in your mid to late 40s and something feels different, your sleep, your mood, your weight, your cycles, do not wait for a doctor to bring it up. Bring it up yourself. Ask specifically, could this be perimenopause? Ask for a hormonal panel that includes FSH and estradiol. You deserve that conversation now, not after years of being told everything is normal. Now here is where it gets really interesting, because most women understand that menopause affects their reproductive system. What most women do not know is how much further estrogen's reach actually extends. Navigating your health journey doesn't have to be a solo effort filled with trial and error. I'm here to provide the clinical clarity you need to move forward with confidence. Subscribe because the next video might save you years of frustration. Number 2, what estrogen actually does in your body and why that changes everything. When most people think of estrogen, they think of reproduction, menstrual cycles, pregnancy. That is where most of the public conversation stops. But here's the clinical reality. Estrogen receptors exist throughout your entire body. Your brain has estrogen receptors. Your heart and blood vessels have estrogen receptors. Your bones have estrogen receptors. Your joints have them. Your bladder have them. Your gut lining has them. Your skin has them. This is why menopause is not a single system event. When estrogen begins to fluctuate and decline, it does not affect just one part of you. It affects every system that depends on it, simultaneously. And that is exactly why so many women in their late 40s and 50s feel like their entire body is changing at once. Because it is. The brain fog is not imaginary. Estrogen plays a direct role in neurotransmitter function and cerebral blood flow. The joint pain is not just aging. Estrogen has anti-inflammatory properties, and its decline can accelerate inflammation in joint tissue. The bladder changes, the skin changes, the gut changes, all of them have a hormonal mechanism. In my clinical experience, the moment a woman understands this, that her symptoms are not random and are not character flaws and are not weakness, something shifts. She stops blaming herself. She starts asking better questions. What you can do with this today, the next time you see your doctor for any one of these symptoms in isolation, a bladder problem, a joint problem, a skin problem, a sleep problem, ask whether the menopausal transition could be a contributing factor. Because the answer, very often, is yes, and connecting those dots is your doctor's job. Hold them to it. This next one surprises almost every woman I share it with, and I share it with every patient I treat after menopause. Number 3, the cardiovascular risk your doctor may never have mentioned. Here's a statistic I want you to hold on to. Heart disease is the #1 cause of death in American women. Not breast cancer, not osteoporosis, heart disease. And here is what changes at menopause. Before menopause, estrogen provides a protective effect on your cardiovascular system. It helps maintain the flexibility of your blood vessel walls. It supports healthy cholesterol ratios. It reduces systemic inflammation. When estrogen declines after menopause, that protective effect is removed, and cardiovascular risk in women rises, not gradually but meaningfully, in the years immediately following the final period. What the research shows is that women who have their menopause before age 45, either naturally or surgically, have a significantly elevated cardiovascular risk compared to women who transition later. But all postmenopausal women experience some increase in cardiovascular risk, and most are never told this directly. There is a second problem here that I feel very strongly about. Female heart attack symptoms frequently look different from male heart attack symptoms. The crushing chest pain that most people picture, that is a male pattern presentation. Women are more likely to experience fatigue, nausea, jaw pain, back pain, or a vague sense that something is simply wrong. These symptoms are more frequently missed by the women themselves and by the physicians treating them. Here's your action step. At your next annual appointment, ask your doctor 2 specific questions. First, now that I am postmenopausal, what is my cardiovascular risk profile? Second, what screenings should I be having that I may not currently be getting? A lipid panel, a blood pressure trend conversation, and a discussion of your family history are the starting points. You have every right to that conversation. Pay close attention to this one. It is the point I feel most strongly about, and it is the one most women tell me they wish they had known years earlier. Number 4, the truth about hormone replacement therapy and why so many women were left without it. In 2002, a large clinical trial called the Women's Health Initiative published results that sent shockwaves through medicine. The study suggested that hormone replacement therapy, HRT, significantly increased the risk of breast cancer and heart disease in women. The medical community responded by pulling back on HRT prescriptions almost overnight. Women who had been on HRT were taken off it. Women who needed it were never offered it. Here is what happened next, and what most women were never told. The research that followed the 2002 WHI results revealed critical problems with how that study was designed and how its results were being applied. The study primarily used one form of synthetic progestin. It enrolled women who were, on average, 63 years old, well past the menopause transition window. The risks identified were not evenly distributed across all women or all types of HRT. Subsequent research, including reanalysis of the WHI data itself, showed that for healthy women who begin HRT within 10 years of menopause or before age 60, the benefit to risk profile looks very different from what was originally reported. For many of these women, HRT not only relieves symptoms, it may offer protective benefits for bone, cardiovascular health, and cognitive function. The Menopause Society, which is the leading clinical authority on this in the United States, now states clearly that HRT is appropriate for most healthy women under 60 who are within 10 years of menopause and who have no contraindications. This does not mean HRT is right for every woman. It is not. There are women for whom it is not appropriate, and that conversation belongs between you and a physician who knows your full history. But it does mean that an entire generation of women was denied a legitimate treatment option based on research that was later substantially revised. What you can do. If you were never offered HRT, or if you were taken off it after 2002 and never had the conversation again, bring it up at your next appointment. Ask specifically, based on the current evidence, am I a candidate for hormone therapy? If your doctor is unfamiliar with the updated guidance, Ask for a referral to a menopause specialist. You deserve a current answer, not a 2002 one. Now we are getting to the information I want to leave you with, because this is where everything we have talked about becomes something you can actually use. Number 5. The 3 questions that will change your next doctor's appointment. Everything I have shared with you today, the perimenopause timeline, the whole body impact of estrogen, the cardiovascular shift, the HRT conversation, none of it is useful unless you can bring it into a room with your doctor and have it heard. So I want to give you 3 specific questions. Write these down. Question 1. Could my symptoms be related to the hormonal changes of perimenopause or menopause? And if so, what testing is appropriate? This opens the hormonal conversation directly and professionally. It signals that you know what you are talking about and that you expect a real answer. Question 2. Now that I am postmenopausal, has my cardiovascular risk profile changed? And what screenings should I be having? This forces a direct conversation about the risk shift that happens after menopause. A good physician will have a thoughtful answer. A physician who dismisses this question is one you may want to reconsider. Question 3. Based on the current evidence, am I a candidate for hormone therapy? And if not, what are the alternatives for managing my symptoms? You do not have to accept you are too old for that, or the risks are too high, without a current, evidence-based explanation. You are entitled to one. These 3 questions will not guarantee you get everything you need in one appointment, but they will change the quality of the conversation. And changing the conversation is where everything starts. I want to say something directly to you before I close. If you have spent years feeling like your body was changing in ways no one could explain, or in ways that no one took seriously enough to explain, that was not you being dramatic. That was not you being difficult. That was a failure of the information that should have reached you, and it reached far too many women in this country the same way. You are not at the mercy of your age. You are not at the mercy of your hormones. The 5 things I have shared with you today are real, they are evidence-based, and they are actionable. You can bring them to your next appointment. You can ask the questions I gave you. You can advocate for the level of care you deserve. Your symptoms were real. The biology behind them is real. And the options available to you, even now, even at this stage, are more than most women have ever been told. That changes today. If this video gave you something useful, whether it is a question to ask your doctor, a conversation to have with someone you love, or simply the validation that what you experienced was real, I would love for you to subscribe to this channel. Every week I post real, research-backed answers to the health questions women over 55 are searching for, but rarely finding honest answers to. This channel exists entirely for you. And if you know a woman in your life, a friend, a sister, a daughter, who is just beginning to notice changes, please share this video with her. She may be in the early stages of exactly what we talked about today, and she deserves to hear it now rather than years from now. Leave me a comment below if something in this video resonated with you, or if there is a question I did not answer. Your questions become my next videos. I read every single one.